Imagine being told you have only months left to live, each day being filled with pain and discomfort, and your independence is slowly slipping away. What would it mean to have control of your future? Across the world, big changes are taking place, changes that conflict with the heart of medicine, ethics, and what it means to die with choice. Currently, in 10 countries and 12 U.S. jurisdictions, individuals diagnosed with terminal illnesses can be granted life ending treatments by their physicians. This practice, known as physician assisted suicide or medical aid in dying, has become a focal point for ethical, legal, and medical debates. One of the earliest known examples of assisted death is that of Socrates. After being imprisoned for impiety and corrupting the youth, he willingly drank hemlock that was provided by a jailer. Though this is not a clear case of physician assisted suicide, the event sparked many early questions about the ethics of voluntary death. The medical profession has been especially resistant to the concept of medical assisted death. The Hippocratic Oath, which is traditionally made by physicians, includes the statement, I will give no deadly medicine to anyone if asked, nor suggest any such counsel. This reflects their commitment to the principle of primum non nocere, first do no harm. However, over time, the interpretation of harm has changed, especially in the context of end of life care. A major factor in the changing of mindsets in medical ethics regarding this topic was the rule of double effect. This principle demonstrated that it could be ethically permissible to perform an action that has both a positive effect and potentially harmful effect, as long as the harmful outcome is not the intended goal. A common example is administering high doses of morphine to alleviate severe pain, even if it unintentionally shortens a patient's life. The legislation of medical assistance in dying in the United States has been a gradual process. Oregon started this movement by passing the first Death with Dignity Act in 1997. This allowed terminally ill patients to request and receive life ending treatment. In the years that followed, other states, including Vermont, Washington, and California, passed similar legislation. As the movement continued to spread, there was a notable acceleration between 2015 and 2022. During that period, six additional jurisdictions joined the movement: Colorado, the District of Columbia, Hawaii, New Jersey, Maine, and New Mexico. A more prominent event occurred recently in 2023 when Oregon eliminated its residency requirement for receiving medical aid in dying. With this change, the state now allows non residents to travel there to access these services, significantly expanding access across state lines. This policy shift has changed things for the nationwide movement. By opening its doors to patients from other states, Oregon has placed indirect pressure on other jurisdictions with legal medical aid in dying to consider similar reforms. Also, the removal of residency requirements could serve as a model for other states, which will intensify the push for a national approach to end of life options. Ultimately, this recent change not only expands practical access for patients, but it also reinforces the right to die movement. As more states reevaluate their laws, the national conversation around assisted death may shift from scattered local debates to a unified discussion about federally protected end of life rights. While may be obvious, the role of autonomy is crucial in the arguments that terminally ill patients use to defend their rights to die. Many patients ask, why am I regulated on what I can do with my own body? In times of debilitating illnesses, dependency, and pain, many people are looking for a dignified escape from this turmoil. Unfortunately, in areas where medical suicide is not easily accessible, many elderly people who are experiencing these hardships take matters into their own hands, using rudimentary methods of suicide that are not always effective and can be painful, uncomfortable, and undignified. The ethical principles of beneficence and non-maleficence mainly affects the dilemma seen by physicians. This ties us back into the Hippocratic Oath of doing no harm. Physicians are taught to do good and to be healers of the sick and comforters to those in pain. It is conflictory to the role of the physician to cause so much harm to a patient as to purposefully end their life. Unfortunately, these ethical principles fight against each other. Beneficence says to take care of the patient, such as in the case of relieving their suffering, while non maleficence would be against relieving suffering if it meant causing them harm, such as in medical suicide. Justice calls an argument against medical assisted death due to the inadvertent pressures that it can cause to vulnerable populations, such as the elderly, disabled, or those without good healthcare coverage. This could possibly make them feel that death is their only available option. Could a society that views suffering or dependence as not part of life inadvertently marginalize those who choose to live despite their conditions? Justice demands that we put safeguards to ensure that no one is coerced into ending their life due to any type of societal biases. While granting relief to those in pain is important, it is equally important to ensure that allowing medical suicide does not take away the rights and dignity of those who wish to endure. As the conversation around medical aid in dying continues to grow, we remain still asking the same questions. What does it mean to die with dignity? Who gets to decide when enough suffering is enough? Physician assisted suicide challenges our healthcare system, our values, and our definition of compassion. Whether you support or oppose it, the issue still challenges us every day with its complexities of new perspectives, emotionally charged stories, and moral reshaping situations.